So we'll go to next speaker. I invite Professor Radhika Tandon. She will be speaking on the role and outcome of stem cell therapy for limbal stem cell deficiency, followed by her next talk on COMET and COSET. Yeah.
Thank you so much. Good morning, everyone. So, in a way, we've had a whole range of history from past to present, and we've also had experience of, getting reports and publications from all over the world. But you have to adapt on what's available to you. So, I just like to give you an overview with that perspective. So if you see as etiology, as Dr. Lomi nicely said, there are a whole variety. So it's largely a clinical diagnosis. Definitely impression cytology is a help, but with the past experience of publications and research, you do know that it correlates. So you don't have to do the impression cytology for every case. It's only if there's doubtful cases, if you're doing some study or you want to prove something in a research protocol. So these are largely the clinical features, and the patient will have vision discomfort and conjunctivalization. However, the problem comes if you go strictly by this. Sometimes a patient will have these features, but the cells are quite healthy in a way, as I'll show you with some examples. So there are these classical features with opacification. There's a disruption of the palisades of Vogt. The other thing to look for is whether there's active inflammation. When talking about impression cytology, again, it's not something which will be accessible to everybody. You'll have to have a laboratory, and you'll have to have a pathologist who's cognizant with it. So if supposing there is any need for anybody to verify, then you can make a kind of a marking on the filter paper strip that you have, so that when you send it to the lab, they will know which part of the filter paper is indicating which side. So you have the cornea, you have the limbus, and you have the conjunctiva. And when you have patients with very extensive damage like Stevens-Johnson syndrome and so on, you must take a separate piece from the, specimen from the conjunctiva, because sometimes it's so severe that there is no goblet cells even in the conjunctiva, particularly in Stevens-Johnson syndrome or inflammatory dry eye. So then you'll falsely get negative on the cornea, and you may wonder about it. So unilateral, bilateral, and also look at the vision and whether the patient is comfortable or not. So here we will look at the various the classification systems that you have, and then when you come to the management, don't forget that you have to restore the ocular surface. Often the patient is very anxious, very keen to go for immediate restoration, but you have to explain that the stem cells, when transplanted, they require a stable and a healthy ocular surface. So you require a healthy soil, which is a substrate. There should be no active inflammation. There should be adequate tears and a healthy epithelium, and so on. So this is the customized approach, and Dr. Lomi had nicely said, don't forget that there is an option of a conservative do-nothing approach, because just as we have said that the stem cells regenerate on the surface, similarly, the patient's own hematopoietic stem cells, they may replenish the limbus and they may improve the situation later on. So it's worthwhile watching for a while. Now, when you have a case of conjunctival limbal autograft, as Dr. Lomi said, you can also combine it with an adjuvant amniotic membrane if there is an associated symblefron. And even a living-related conjunctival allograft can work in such situations. For example, if there's a bilateral deficiency. But when you have when you're taking an allograft, you must use a pretty heavy immunosuppression. So you'll have to use oral steroids and very heavy topical steroids as well. But this is an example that with proper meticulous care, even a live-related autologous, live-related allograft can work. The trouble with these is that you can have rejection, so you do have to watch very carefully, and there is clinical improvement both in vision, patient comfort, and corneal clarity. The other option is a cadaveric stem cell graft. Here you can either apply it in the form of a lenticule. So here you are not removing the epithelium on the ocular surface. It takes a little bit more time. But on the other hand, you're not exposing the entire cornea to a raw surface. And also sometimes if the cornea is thin and you expose it to a raw surface, it tends to undergo melting. So this can be done for a donor rim. If that is done, then you can use an age less than 40 years, as fresh a tissue as possible. But it does require systemic systemic immunosuppression. So these are examples of cadaveric limbal stem cell transplant. And the variation has been said that if the condition is so bad, initially you do this, and when it improves to some extent, then the further step can be topped up with a SLED procedure. This is an example. Sometimes you get excellent results and sometimes not so. So this is the limbal stem cell allograft. As you can see, the pictures are quite encouraging. This is an example of a 6 months comparison of the conjunctival allograft versus a keratolimbal allograft. So what is the difference? Conjunctival allograft will be taken from a living relative, which is a fresh tissue, and a keratolimbal is taking from a cadaver tissue. There you have to take a little bit more deeper because the stem cells require to have what they call as their comfort zone, and they require the cell-cell interaction to be given an encouragement to grow. And if you have a very severe case or monocular patient, you can even do an annular corneoscleral allograft, which has been done like this. And a large diameter LK is what we recommend if you have a thin cornea, because when you have a cornea where after removing the pannus there's going to be less than 300 microns, then that cornea is too thin and it tends to melt. So if you want to do a one-stage procedure, you can do a large LK, so a younger donor where you include the limbus and you suture it in. And then if later it does fail, you can do a simple penetrating keratoplasty later on. So these are a few examples of large LK. So large lamellar keratoplasty, this is useful if you have a thin cornea. Now, when you talk about cultured limbal stem cells, here again, there are several techniques of culturing. You have variations where you have the suspension culture, but we had to see that in our conditions, what can be the locally adaptive methods. So in a sort of low resource setting. So we have cultured them using amniotic membrane, and then after confirming in the lab that the cells and the technique was adequate, then we proceeded to the patient. But there is one drawback of this procedure, that you're not verifying the stem cell each and every time. So you have to first standardize your method, confirm that what protocol you're following is doing what it is supposed to do, and then follow that protocol strictly later on. So this was a kind of a criticism of this procedure when it was considered that it could be when you could go for DCGI approval and make it as a kind of a standard accepted procedure. This was a criticism. So they said, no, you have to prove it by an RCT. And then, of course, when you have failures, you can look at causes. It could be inflammation, it could be secondary infection, or it could be a rejection. If you have an acute rejection, this is only with allografts, then you can have instant pain, redness, photophobia, and then you'll have edema of the lenticules, and of course epithelial defects, myopia is treated with topical steroids and sometimes even systemic steroids. So now what about the long-term success? So everybody would have individual photos, some are doing well, some are not doing well. So what can we tell the patient to expect or the family to expect? So there's a wide variation. What are the strategies? Of course, it will depend because different cases would have different individual concerns. Sometimes there may simply be non-compliance to treatment. The patient may have just stopped the treatment or not use it regularly because of side complications or because of affordability. So therefore, we did a systematic review of what are the outcomes of various surgical interventions for the treatment of limbal stem cell deficiency. And unfortunately, there are no RCTs. But based on the large case series, etc., available, just look that all the procedures have reasonably good anatomical success rate. So that's in a way good news. So whichever surgeon has whatever access or whatever the comfort zone, you can do any of these procedures. And the gain with visual acuity was better with SLET and keratolimbal allografts than with CLET. But here again, there could be variations in case selection. So that is something you have to remember when you do a systematic review like this, and particularly when there was no standardized RCT. And here giving you an example of a direct lenticule, limbal lenticule, which is applied. And as you can understand, it will take time for this lenticule to expand. And initially, the criticism of this was that you would have to use a larger, as Abhijit also said, take a larger piece. So in order to standardize this, in our RCT, we took the same size piece. So this is, I would like to acknowledge the contributions of the stem cell laboratory at AIIMS and the funding we got for the Department of Biotechnology. So with that, I'll go to the next slide, the next one. So in a nutshell, I will say that you can be confident of doing whichever procedure is accessible to you, just keeping these principles in mind. Now, what happens when you have a bilateral case? So bilateral cases are challenging. We do have an option of live related, but autologous is always better because these patients are quite sick and you want to avoid using systemic immunosuppression. And in our patient population, even that systemic immunosuppression is expensive. So we have done a comparative evaluation of cultivated oral mucosal autologous and also cultivated conjunctival. So just like you have stem cells at the limbus, there are also conjunctival stem cells deep in the fornix. So the objective was to evaluate the efficacy of transplantation of cultivated oral and cultivated conjunctival epithelial cells, look at the efficacy and safety. And since there was a shortage of RCTs for unilateral stem cell deficiency, we also incorporated a pilot RCT, a limited RCT is this over for one talk or second talk? Second talk also time over? Okay, so just remove, okay. To evaluate and compare the efficacy of direct limbal lenticule with SLET and CLET in patients with unilateral limbal stem cell deficiency. So in vitro culture, we do require a CGMP lab. We do not have a certified CGMP lab at AIIMS, but we have a CGMP compliant lab. And the basic, it works that in the OT, the tissue is harvested and put into the transport medium, and then it is transferred to the lab and grown. And they were randomized to receive either conjunctival cells or the oral mucosa. And for the unilateral cases, the direct limbal and SLET were done by the surgeon himself in the OT, and the cultivated group went to the lab. One change we did is, I thought that with the microscope and the surgeon having so much of expertise, and similarly in the lab, there is another person who's a non-surgeon who's cutting it up into pieces and transplanting it. So I thought it'll be good to validate if you have a pre-chopped versus an intact piece. So the lab would be given 2 specimens. So whatever piece we would take, we would break it in half, cut it in half. One half the surgeon would split into those 8 to 10 to 12 explants, and the other would be left to the lab. And we just wanted to see how they would fare. We looked at the unilateral cases, DLT, SLET, and CLET, and in our experience, they were equally good. And in the case of characterization of the cultivated limbal epithelial cells, they met the criteria. The only thing we found is that somehow the lab felt more comfortable with the intact pieces, and they felt that they had a higher growth rate and a quicker growth rate. So it's possible that the cells, the process of chopping is making multiple cuts, and in the process of going to the lab, and they're usually processed the same day, it's possible that that is producing some kind of an irritation, and the cells are, they would count the pieces, whereas when it's intact in the lab, it's done fresh. So this is something that's still work in progress. And again, it will depend upon the expertise of the person in the lab. So if supposing that that person is not comfortable doing it on their own, then the surgeon can cut the pieces and send. Though of course now CLET is completely phased out, and it has been completely overtaken by SLET. But this is just to give a validation for the process. And then these are representative AIOCT images after longer follow-up, and as you can see, they are all comparable. And for the bilateral cases, comparing COMET versus COSET, here we found that these were all cases with bilateral Stevens-Johnson syndrome or chemical burns. There were very few patients of chemical burn, only 2 or 3. Largely, they were Stevens-Johnson syndrome. So here, we found that the oral mucosa grew better, and there was at least 4 patients where the conjunctival cells did not grow at all. So therefore, I would say COMET is a better procedure. Our thought process was that COMET has been described to show vascularization, and maybe the conjunctival epithelial transplant would do better. However, in a head-to-head comparison, the ones which grew, there was no difference. So therefore, I would say that COMET is a good option. And then the representative AIOCT and post-op pictures. And the standard quality control checks that were done. And so the research leads were that unilateral cases, all 3 are good. So SLET is a very, very good procedure, and the research leads along with scientific relevance of our bilateral cases, showed that pre-chopped versus chopped, the intact ones were better. And you can see the outcomes for COMET as well as COSET. They are also good, with improvement in the ocular surface as well as vision. And here it also improves with time, but it's extremely important to also monitor what are the compliance with the post-op medication. So these are examples of the H&E staining, as well as the scanning electron microscopy and the immunohistochemistry to show that the quality of the cells is as expected. And the BCVA in DLT, SLET and CLET groups, all of them improved. So with that, I would say that there's a definite role of limbal stem cell transplantation, and we had taken patients who had already gone through a long process and they had not shown any further improvement. Regarding your choice of treatment, I would say SLET is a good option, and in case of an acute burn, that's another discussion, but in acute burn, the team led by Geeta Iyer has shown that you can combine amniotic membrane with an allo-SLET for acute burns, because you don't want to sacrifice the tissue you've taken from the other healthy eye. So this is again a validation of all those concepts. Thank you very much.
Thank you, ma'am. That was a wonderful insight from this new technique, the COMET and COSET. If there is any question to ask for ma'am, if there is none, yes, ma'am. I would like to know, like, for this COMET, your culture, cultivated in the lab. So how long, after how long we can use the cell used to grow? And number two is, if that growth, the culture, if we use it and then if some are left behind, can we reuse it later on if for the same patient, if we can reuse it and save in the eye bank, or we can use it or not? That.
Yes. So good questions. One is, generally it is described to take up to 3 weeks, but in our experience it's always grown within 2 weeks. So within 2 to 3 days you can see the explants. So when they in the lab, they put the cells to culture, they leave it in the medium for 48 hours without disturbing it because they want to stick, and after 48 hours they check, and you invariably start seeing the outgrowths, and by 2 weeks you have a confluent layer. It is described as up to 3 weeks, but generally maybe the conditions that we have, so you can schedule your case electively at 2 weeks. You do the harvesting and you schedule the case after 2 weeks. In some of the cases, the first time we found that cells did not grow was in the COSET. So that was a new learning. So in that case, you have to warn the patient. Secondly, that if you have transplanted it, and can you keep another backup? So in this study, we had two. Each patient had two cultures. One was the intact and the other one was the one where the pre-chopped was sent. But traditionally, people don't take two pieces because they only grow in one sheet. So once you have taken the sheet and applied it in the lab, then, in the OT, then you cannot leave that residue back into culture. So you cannot save it in the lab and all, because it has to be, it's an ex vivo growth, and it's considered as maximum manipulation of cells outside the human body. So therefore, you don't know what's going to happen to the cells, so therefore it's not recommended that you keep it and save it for a later date.
Thank you, ma'am. And is there any preparation for the patient, for the particular patient to harvest from the oral mucosa?
Yes.
They need anything?
Important question. So yes, you have to prep the patient, check their oral hygiene, and they start using betadine or chlorhexidine gargles 3 days before, and after the procedure also that continues. So 3 days they start, and then a local treatment with betadine, and then harvesting. It's a very superficial harvesting that's done, and you don't need to suture it. It just heals very, very easily. And avoid hot food after it, hot and spicy food. And I've never had any patient complaining of mouth ulcers or any discomfort.
Thank you.